presentation today is Screening for Vision, the Aging Eye. Dr. Au, please.
Right, good afternoon, everybody. Can you hear me? Right, it's nice to see so many of you here. Today's my privilege to talk to you about screening for vision. As we know, the prevalence of vision impairment and blindness increases exponentially with advancing age. And in fact, blindness is one of the most common disabilities, and eye disease ranks third after arthritis and heart disease as the most common cause of functional impairment in the elderly population, which is also one of the most feared disabilities. Blindness in the elderly has a negative impact on the quality of life. It is associated with increased accidents resulting in falls, injuries, hip fractures, road traffic accidents. It is also associated with an increased mortality. People who are visually impaired dies at a higher rate, 3 to 4 times higher than those who have good vision. And in fact, the life expectancy can be reduced by up to 4 years in those who are visually impaired. It is also associated with depression, higher risk of depression in those who are visually impaired. Blindness also is associated with reduced productivity and the loss of functional independence. As the population of Singapore ages rapidly, the life expectancy increasing, and also the proportion of elderly in our population increasing, we can expect a corresponding increase in the number of age-related eye diseases we see. And I propose that this is a major public health problem that we're going to face in the new decades to come. Right, so there's no room for complacency. Interestingly, about maybe 1 or 2 decades ago, we have editorials by local ophthalmologists that says that blindness is not a problem in Singapore, and we don't need any prevention of blindness activity in Singapore. Visual acuity is the clinical measure of the eye's ability to distinguish details of the smallest identifiable letter or symbol. It's usually expressed in a fraction. For example, if you see 660, that is the level of vision you see, and you can see the object at 6 meters, what a normal person can see at 60 meters. So if your vision is 6 to 12, then you can see at 6 meters what a normal person can see at 12 meters. The WHO defines vision impairment as a visual acuity worse than 618, but equal or better than 6120 in the better eye. Right? So if you're testing the better eye, then of course the worst eye has a worse visual acuity than this. And for blindness, the WHO definition is a visual acuity worse than 6120 in the better eye. So amongst Singaporeans, what is the prevalence of vision impairment and blindness? In a population-based study in Tanjong Pagar, amongst Singaporeans of Chinese origin aged 40 to 79, 1.1% of people are visually impaired, both eyes, and 0.5% of people are blind in both eyes. So that's about 1 in 200 people are blind in Singapore. What are some of the more common sight-threatening age-related eye diseases? Cataract is still the #1 cause of blindness. Cataract, of course, is easily treatable. Glaucoma is the #2 cause of blindness. Glaucoma can be treated or at least halted with medications and surgery. So in the world, the WHO data shows that cataract is the most common cause of blindness, followed by glaucoma, and then followed by age-related macular degeneration. So our pattern of blindness is actually follows the rest of the world, or actually in the developed world, the age-related macular degeneration is the most common cause of blindness. In rich countries where there are sufficient doctors, access to eye care, cataract, which is treatable, easily treated, and glaucoma, blindness are also prevented with the use of eye drops and surgery. So in these countries, the more difficult to treat conditions such as age-related macular degeneration surface as the most common cause of blindness. And this is in all the developed countries. So although Singapore has attained a developed country status, or pattern of blindness is still quite similar to those in the developing countries. For diabetic retinopathy, although not strictly age-related, it is the biggest risk factor is the duration of the disease. And of course, as you grow older, you tend to get more diabetic retinopathy. Other sight-threatening eye conditions can also occur in older persons, such as retinal detachment, which is treatable, macular hole, which again is treatable, myopic macular degeneration, very similar to age-related macular degeneration, but now the risk factor is severe myopia, and this, of course, as you know, is very common in our population as well. Macular pucker or epiretinal membrane is again treatable. Advanced pterygium, for those who neglect their eyes, they may allow a growth on the surface of the eye to grow across the visual axis, and that can be a cause of poor vision as well. And also, age is related to vascular occlusive disease such as retinal vein occlusion. Right, can these diseases be prevented? We talk about primary prevention, which is preventing a disease from occurring in the first place. So for those who do not yet have the disease, can we prevent them? If you look at the literature, there's currently no primary preventive approach on proven effectiveness for many of these age-related eye diseases. Essentially, nobody has done a randomized controlled trial, which is of course very difficult to do. But data from epidemiological studies have shown that there are risk factors that are associated with some of these eye diseases, such as exposure to the sun. Actinic rays are bad for your skin, bad for your eyes. It causes cataract, pterygium, pinquicular. Some people believe it also causes AMD. So of course, if you wear sunglasses, potentially reduce that risk factor. You can reduce the risk of cataract, possibly AMD as well. If you have diabetes, of course, controlling diabetes well can reduce your incidence of diabetic retinopathy and progression of diabetic retinopathy. And of course, smoking, which is largely self-inflicted. Smoking increases the risk of AMD by 3 to 4 times, and for cataract by 2 to 3 times. And smoking is a way of reducing the risk of getting cataract and AMD. What about secondary prevention? Secondary prevention is preventing a disease from getting worse after the onset of the disease. And this, I believe, is a more valuable approach than primary prevention for eye diseases. This is where screening comes in. Early detection and timely intervention increases the visual impairment and blindness prevalence. It improves quality of life, and it decreases the associated morbidity and mortality associated with blindness. This visual acuity chart, usually the Sneller's chart, is the usual method for screening for visual impairment in primary eye care settings and in eye clinics. And the best VA should be obtained in each eye with the patient's habitual optical correction. So the patient usually wears glasses, then you should put on the glasses or contact lens. And if necessary, proceed to repeat the test with a pinhole. Screening questions are not as accurate as visual acuity testing for identifying visual impairment. Evidence is limited on the use of other vision tests, including endoscopy and fundoscopy, in screening in a primary eye care setting to detect visual impairment due to AMD and cataract. When you look at the literature, unfortunately, you're looking for very strong evidence of screening asymptomatic people in the population, subjecting them to intervention, and measuring whether there's any functional improvement. Unfortunately, there are no studies that are done this way. In fact, it's very hard to find evidence of treatment for people who are asymptomatic. The US Preventive Services Task Force concluded that there's insufficient evidence to indicate whether screening older adults for visual impairment improves functional outcome. And they also mentioned that the balance of benefits and harm cannot be determined. Well, however, we know that visual impairment is common in the elderly, and many of these causes of visual impairment, cataract, glaucoma, detachment, macular holes, they can all be treated, right? And since the majority of these causes of visual impairment can be treated, we believe it's beneficial for community-dwelling adults to be screened for visual impairment. So the proposed algorithm for vision screening is this. You check the visual acuity one at a time with the optical correction of the patient. If the patient is not complaining of poor vision, has a vision of 6/12 or better, then that is acceptable and can be considered normal. And the patient should be screened again subsequently 1 to 2 years later. If they have a poor vision of 6/12, worse than 6/12, then that will be considered abnormal. It's closer to impaired vision, and the test should be repeated using a pinhole. If they also wear glasses, because wear glasses plus the pinhole. And then if the visual acuity improves to 6/12 or better, then a large component of the impaired vision is due to a refractive error. And for these patients, you can refer them to an optometrist or an optical outlet. If the visual acuity is still worse than 6/12, then consider referring them to an eye specialist for further evaluation. So the post-screening follow-up, older adults with VA of 6/12 or better should be screened every 1 to 2 years. Individuals with visual acuity worse than 6/12 initial screening should have their VA repeated with pinhole. And those who have a substantial improvement to 6/12 or better with pinhole are likely to have a refractive error and should be referred to an optometrist or optical outlet. And those individuals with pinhole vision worse than 6/12 may have eye conditions other than refractive error and should be referred to an ophthalmologist. So in summary, visual screening in older adults can reduce blindness and its associated negative impacts. We expect it to decrease mortality, decrease mobility in terms of depression, accidents, fractures, falls, and increase the quality of life of our elderly people. With this, I thank you for your attention.